Today I'm going to treat the case of ovarian cyst. Patient Mrs. GS, 71 years of age, wife of Mr. FM, resident of Lahore, married for 55 years, housewife.
Nice.
Okay. Para 5, abortion 0, all SVDs with last child born 40 years of age, had surgical menopause since 1994. She presented to us with complaint of lower abdominal pain with nausea and vomiting for 1 month. She was in usual state of health 1 month back. Then she started having lower abdominal pain for 1 month, sudden in onset dull, non-radiating associated with nausea and vomiting. 1 to 3 episodes per week with no relieving and aggravating factor. She is also having a history of increased urinary frequency for 3 months. She had her ultrasound done on 23rd of April, on which there was an incidental finding of right ovarian cyst. She had no significant history of weight loss, fever, or any vaginal discharge, spotting, or bleeding.
No, this patient actually was referred by a physician who saw the patient first, and because he had presented with complaints of nausea and vomiting for 1 month. So that was the problem, and the patient went to a physician, and the physician during their workup found out that she had gone away. And this is not unusual for women to with the ovarian cysts or ovarian tumors, larger ovarian tumors, particularly in this case, that doesn't hold as much true. But there are large ovarian cysts which go unrecognized by the patient. They do not realize that they have, and they start having a gastrointestinal symptom because of essentially pressure effects. And therefore, they go to the physicians. And the diagnosis sometimes is made for the first time with the physician. So from that point of view, this history was kind of typical that she went to a physician, and the physician then referred to the gynecologist.
Okay. Her gynecological history, her age of menarche was 15 years of age. Her previous menstrual cycle was regular with average flow till the age of 30 years. Then she started having irregular menstrual cycle, for which she had her vaginal hysterectomy done in 1994. She had no history of contraception use and no history of cervical smear done. On her obstetrical history, she is para 5, abortion 0, 5 alive issue, 1 male and 4 females. All of her pregnancies were full-term pregnancies that ended up in normal vaginal delivery at a private hospital in Lahore with no complications during pregnancy, labor, and postpartum. And she recalls all of her babies were of average weight at birth. Her medical history. She is hypertensive for 5 years, for which she is taking calcium channel blocker and angiotensin receptor blocker, and she is also taking alpha blocker for it. And she is also a non-case of ischemic heart disease, for which she is taking aspirin and atorvastatin. She had history of right-sided hemorrhagic stroke 5 years back, and she is also a non-case of depression, for which patient is taking benzodiazepine at night. She had history of vaginal hysterectomy in Fatma Memorial Hospital in 1994, and she is also having open reduction internal fixation of left arm due to left arm fracture in 2004 in Ittifaq Hospital. Her daughter was diagnosed with breast cancer, and she has no known allergies and no habituations. On examination, an elderly female sitting comfortably on bed, well oriented in time, place, and person. Her height was 5 feet 3 inches, weight 35 kg with BMI 27.3 kgs per meter square. 70 kg. Her pulse rate was 97 beats per minute, blood pressure 140 by 85 millimeter of mercury, respiratory rate 20 per minute, and temperature 98 Fahrenheit. She had left arm weakness. The power of the left arm muscle was 3 by 5. All the other muscles were having normal power. No pallor, jaundice, cyanosis, thyroid was not enlarged, lymph nodes were not palpable, both breasts were symmetrical, and no mass was palpable. For abdominal examination on inspection, abdomen was non-distended, central inverted umbilicus, no visible scar marks, pulsation, discoloration, or bruising of skin. On palpation, abdomen was non-tender. There was a right iliac fossa fullness, no shifting dullness, bowel sound were audible. On bimanual examination, vulva vagina was normal looking, vaginal wall healthy, uterus was absent, there was a right fornix fullness, there was a cystic mobile mass of about 12 into 14 centimeter palpable on the right side just above the vaginal vault, and the lower limit of the mass was reachable.
Lower limit of what are you describing? Bimanual examination.
Ji sir.
Any comment on this bimanual examination? The first line, vulva, vagina, normal looking, vaginal vault healthy. Is that bimanual examination? That is inspection.
Okay, sir.
That's inspection of the external genitalia
Ji sir.
and then speculum examination.
Okay, sir.
You so stop having that fixed statement, vulva, vaginal, normal looking.
Okay, sir.
This is typically coming out from one particular hospital in Lahore, vulva, vaginal, normal looking.
Okay.
So you just say that external genitalia or vulva look normal on inspection.
Okay, sir.
On speculum examination, vaginal walls look normal and the vaginal wall also looked healthy.
Okay, sir.
So that's speculum examination. This one line actually would require two headings. One is inspection of external genitalia,
Ji sir.
and number two, speculum examination.
Yes.
So you have to be careful about that. This is not bimanual examination.
Ji sir.
And don't lump together vulva and vagina. They are separate areas, separate structures.
Ji sir.
So vulva or external genitalia normal looking, vaginal walls normal looking, and you also need to make some comment about the discharge of the secretion, normal secretions, were they present or not, or normal vaginal discharge. And now she is a 71-year-old woman,
Ji sir.
and she had a hysterectomy almost 30 years ago.
Ji sir.
Ovaries obviously are not functioning. Under these circumstances, do you really think that vaginal walls would be looking normal, or would they have? What do you mean by they look normal?
Sir,
What changes do you expect in the vaginal walls?
sir, atrophic.
Hmm?
Atrophic was it?
Yes, atrophic, because they would be atrophic, and then you also need to देखो सवाल पिछली दफा मैंने लिखा है पता नहीं तुम लोगों ने जाके कितने देखे कि how do you describe an atrophic looking vaginal wall? What is the appearance of that? And how does it differ from a normal looking vaginal wall? And when we say that there was a small amount of normal looking vaginal discharge, because that's normally is present. Okay. So therefore, you would say that there was normal looking discharge, or the vaginal walls were dry, or the color of discharge, or whatever, you make a comment about that. There are a small amount of normal looking vaginal discharge. And you will next time remind me and tell me about the appearance of atrophic vagina. An atrophic healthy vagina, healthy atrophic vagina, and a vaginal wall which is the seat of atrophic vaginitis. So what are the features of atrophic vaginitis? And therefore, it should be inspection of pelvic examination.
Ji sir.
Pelvic examination would be the main thing. Then is inspection of external genitalia.
Ji sir.
And that is where the headings come handy, because they make you more, methodical. And you know what is the significance of various things. And you just don't blurt out vulva vagina. So it is pelvic examination. The components of pelvic examination are inspection, speculum examination, and bimanual examination. And sorry, Prof. And you were cystic, mobile, about palpable on right side, all right. And what did you say about reaching the lower limit of the mass? Did you do that on pelvic examination or were you talking about abdominal examination?
Sir.
Because when you are doing a pelvic examination, you are approaching the lower part of the mass, whatever it is, or the uterus.
Mhm.
So you can't say that you can reach the lower. That is something which you do on the abdominal examination, because when you're doing that and you can place your hand on your ulnar border of the hand and you feel that you can lift up the mass,
Yes.
then you would say that you can access the lower border or lower part of the mass by which you can, it is mobile enough to be lifted up with the hand. So that is something that you do on abdominal examination. You don't make a mention of that. So this is one area which why did you do shifting dullness if the abdomen was not distended or there were no features of any ascites? Still you would do it?
No, sir.
Why not? मैंने अगर ऐसे इतराज कर दिया तो उस पे वो ऐसा तो नहीं करोगे शिफ्टिंग डलनेस वाली बात
It's a
इसमें
part of like
and that
procedure,
is
but
how actually that is how you rule out some ascites.
okay, sir.
The patient may not have obvious ascites or fullness, so उसलिए shifting dullness आप पहले उस तरीके से कर लो. चलें आगे.
Differential diagnosis include benign ovarian cyst, malignant ovarian cyst. As on examination,
बस
the cyst.
और नहीं.
Sir, I thought appendicitis or appendicular mass, but then the history was not suggestive of it. Then I thought of hydrosalpinx, like in history or examination. So I think
No, there are, you see, when you are making a differential diagnosis of lower abdominal mass,
Yes.
then they will be gynecological and non-gynecological. And in gynecological, then of course related to ovary and, as you said, tubes, because you know that only hysterectomy was carried out and tubes and ovaries were not removed. Probably you did not make a comment about whether the ovaries were conserved or not at that time.
Yeah.
What you should have added at that time was that she had a vaginal hysterectomy and the patient doesn't has operating notes or she doesn't recall whether ovaries were removed at that time or not. But since you already had the benefit of having seen her ultrasound, so therefore you knew that there was a cystic mass and that the other ovary was also seen on ultrasound, which was apparently normal looking with a small cyst in it.
Yes, sir.
So because of that, your approach to this, as a matter of fact, you see, by the time you reach differential diagnosis at this stage, this is before investigations. So, and if you know the investigations beforehand, therefore that will cloud your differential diagnosis in case presentation. And your differential diagnosis at this stage has to be based on history and the physical examination. Because on the basis of that, you make a list of differential diagnoses, 2, 3, 4, not a very long one. And for example, you can say that in this case, there can be gynecological masses, pelvic masses, and abdominal masses. So what are abdominal masses? What are pelvic? Make a list of those. What are pelvic masses that can present abdominally or they can be palpated on pelvic examination? And what are the abdominal masses which are present in the lower abdomen? So you should have a list of those, right? It's a formidable list. If you look at that, 12-13 उसमें 12-13 उसमें आ जाते हैं. तो वो list बना के आपके ज़हन में होनी चाहिए. And then out of that list, you will identify and select those which are applicable or which would be relevant in this historical perspective. Right?
Okay.
Chalo.
Malignant ovarian cyst as the patient.
If I say that she may have a mesenteric cyst, if I say that she may have a hydrated cyst, how would you argue against that? Because at this time you don't have the benefit of the
investigation. Yes.
ultrasound नहीं है आपके पास.
Yes.
ठीक, चलिए.
On his investigation, her complete blood count was done on 24th of April 2024. Her hemoglobin was 12.3 grams per deciliter. WBC count
वो आपको बता दो उसमें जो जब इतनी सारी लंबी हो ना तो सारी नहीं पढ़नी है।
जी सर।
अब जो उसमें से जिनको आप
Significant.
रेंज करना चाहते हो तो वो सारी नॉर्मल रेंज में थी। इसमें maybe you want to make a comment about CA125 that these tests or these values show that the patient is in a reasonably healthy state of status and only and CA125 is also normal. बाकी सारा कुछ normal.
Okay sir.
लिपिड प्रोफाइल क्यों करवाई थी आप?
Sir, patient was ischemic heart disease patient. So, to rule out atherosclerosis, lipid profile was done.
So she is already on statins, isn't it?
Yes, she was on statin.
तो लिपिड प्रोफाइल करवाई?
जी सर करवाई थी।
हमने करवाई थी?
कोई भी थी, already हुई थी।
Already हुई थी।
जी।
The patient came from a physician, that's why लिपिड प्रोफाइल उनकी हुई भी थी और वो उस तरह से था। हेलो हाँ जी मैम। हाँ जी। हाँ जी। अच्छा ठीक है तो फिर क्लास के बाद ठीक है। हाँ जी।
Her ultrasound was already done on 23rd April 2024, in which a thin simple cyst with clear content.
इस सेंटेंस में कोई चीज आप thin simple cyst with clear content.
Right.
इसमें कोई चीज है? Add something? A thin walled cyst. Walled का लफ्ज इसमें मैं सही है। Cyst thin या thick नहीं होती, उसकी wall की बात कर रहा हूँ। A thin walled simple cyst. Why is it important कि thin walled है या thick walled है? क्या उसमें क्या फर्क है?
Sir, thick wall usually endometriosis or malignancy में होता है और thin wall is benign. Is the feature of benign cyst.
चलो ये next question is features of malignancy on ultrasound, on physical examination and on ultrasound of an ovarian cyst.
Measuring 7.8 into 7.6 into 8.4 centimeter in pelvis just above the right side of vaginal wall. No solid component seen. Thin eccentric single septum seen. On MRI that was done on 30th of April 2024, that showed right adnexal cyst measuring 10 into 8.5 into 8.5 centimeter with no internal septation, solid component, enhancing papillary component. Left adnexal simple cyst measuring 1 into 1.4 centimeter, and there were no pelvic pre-fluid seen and lymphadenopathy seen.
Do you think this MRI was justified? MRI should have been carried out.
Sir, सर अगर हम पेशेंट की एज देखें, शी इज पोस्ट मेनोपॉजल and her CA120 and her symptoms are also associated with non-specific GI symptoms that are more suggestive of malignancy. But if you
क्या कौन से symptoms?
Non-specific GI symptoms and also the age of patient.
Anyone who has nausea, vomiting, etc. would be is likely to have malignancy.
No, sir. Ultrasound is benign.
When ultrasound is there of 23rd of April and that shows a thin walled simple cyst, clear content, उसमें और कोई नहीं है, and the left ovary looks normal with a small cyst, about 1.5 centimeter. Then what is the utility of MRI? Has MRI made us any wiser?
No,
it
sir.
hasn't.
No.
And therefore, I think that we should ask ourselves when we recommend this kind of investigation, that is it really essential? I am probably we have good ultrasonologists on whose reports I rely quite a lot. But still, when there is an ultrasound report by a qualified ultrasonologist, then I think that you should have strong reasons before you advise MRI. I myself, I wouldn't have advised MRI in this patient. And I'm sure that this was done already before she came to me. So therefore, I have an objection to this, that she did not need an MRI. Just the fact that an investigation is available does not justify carrying out that investigation. You need to look at the costs of that. Someone is bearing the cost. The patient is bearing herself, or it is the state or the government that is bearing the expense, and that adds to the workload, etc., etc. So therefore, similarly, on the list of the tests on the other side, you should have good justifications for doing liver function tests, for renal function tests, echo, etc. And since you said that she had history of ischemic heart disease, and therefore that workup was carried out by the physicians, that's okay. But you must have justification for each and every investigation, even hemoglobin estimation or urine. What is the significance of that, and what do you want to identify? What do you want to find out from that urine examination? And what are the significance of various components? So therefore, you should be ready in each component of that examination about justifying that. Chaliye.
The diagnosis was ovarian cyst. Whether it is malignant or benign, that will be confirmed on histopathology report, and the histopathology report of the patient is
बिल्कुल
available.
आपकी बात सही है कि histopathology report, but लेकिन अभी मैंने कहा था कि आप physical examination when you do of the patient, like abdominal examination, if there is a larger mass, then there are features on history, on physical examination. For example, on history, rapidity of growth. A small mass which has rapidly over the last couple of months has increased in size, that is a sign of, for example, malignancy. And there are others which I have asked you guys to find out and make a list of that. Similarly, when you perform a laparotomy, the abdomen is opened and the mass is right in front of you, then there are features which would suggest on examination of the mass itself. Then you look at the features. What are the features which indicate that it is? What are the features for us? Benign, let's say cyst or tumor, and what are the features of malignancy in that tumor? So वो भी उनकी भी list बनाओ. एक वैसे history of physical examination की, और एक at the time of surgery that you identify, because sometimes you have to make a decision about the steps of surgery that you are going to take, the extent of surgery that you are going to take. We have all made mistakes. I have also made mistakes. Many years ago, almost 35 years ago, I was operating on a young girl, 25. She 25 years of age. She had one child, and she had an ovarian tumor. And I did laparotomy. There was a fleshy, solid mass which didn't look good. And I called in Dr. Rashid. I was associate professor at that time. And I asked him to see what does it look like. Now the decision was to be made whether to do hysterectomy and the salpingo-oophorectomy of the other side, or just remove this mass. Now, one can argue about that you would just remove the mass in such a patient, and if there were no other features, and get histopathology. And if the histopathology turns out to be malignant, then you could go back again and do the rest of the surgery which is required. But in that particular patient, we made a decision of removing the uterus and the other two. And that turned out to be a wrong decision, because the tumor turned out to be a benign one. And now, one thing is that patient's fertility was gone for always. But although I put her on, I explained to her and all that, and put her on a hormone replacement therapy, at least for 15 years came me after that surgery. But then obviously she was lost to follow up. So that is one. And I also remember another patient that was here, in whom that was a young girl. I mean, she was in her 20s, late 20s or early 30s. And I had explained to them about this. When we did the laparotomy, it was a suspicious looking
Nice.
tumor of the ovary. We removed that, but we didn't remove the uterus and the other ovaries, and we closed the abdomen. When the report came in, the patient was told that she needs to have a laparoscopy. And but they were quite annoyed by that. Why wasn't it done at that time, etc., etc., or they didn't want to. So they went away. So it is important that in such patients, when the ultimate approach of surgery would depend upon, and if you don't have the facility for uh, a frozen section or immediate recourse to that kind of facility, then there should be a thorough discussion with the patient, with the family about the consequences, about what kind of surgical approach you are going to adopt, what level of surgery will be carried out, and what can be the outcome, and would there be a later need for a later repeat surgery or not. So that is something which should be properly discussed in detail. चलिए जी, आपने यहाँ पे ये लिखा कि डायग्नोसिस जो है वो तो हो गया, आपने यहाँ पे डायग्नोसिस विल बी मेड ऑन हिस्टोपैथोलॉजी रिपोर्ट नहीं है, यहाँ पे आप कहोगे कि
Definitely.
डायग्नोसिस इज दैट ऑफ एन ओवेरियन सिस्ट.
जी sir.
Whether and I would want you to make a diagnosis, and also because of the features of that, apparently the features, ultrasound features appear to be, and the rest of the investigation, they show that it's more likely to be a benign cyst,
Yes.
because there is no evidence of ascites, neither reported on ultrasound or MRI, nor on examination. And therefore, this is likely to be benign, but ultimately, of course, it's the histopathology that will be final thing for the diagnosis.
जी
Actually, so diagnosis जो है इसमें है ovarian cyst, more likely a benign.
Yes. Case summary. A 71 years old female, para 5, abortion 0, all SVDs, postmenopausal, non-case of hypertension, stroke, ischemic heart disease, depression. Presented with lower abdominal pain with nausea and vomiting for 1 month, cystic mobile right pelvic mass on examination, and thin wall right adnexal cyst on ultrasound.
आपने mobile right pelvic mass on examination, which on ultrasound was found to be a thin one. Which on ultrasound, because we're talking about the same mass.
Okay.
Which on ultrasound showed itself to be a thin walled ED, walled right adnexal cyst, right?
जी.
This is good. This is the kind of summary that you need to present. You see, you've presented all the, or you put in all the relevant points, and it is just 4 lines. So that is all what you need in this kind of. हाँ, अलबत्ता थोड़ा सा और अगर करना हो तो अगर 1-2 चीजें और डालनी हो तो नॉन केस ऑफ ये के ऑब्लिक्स नॉन केस है, वो चलो मतलब हाइपरटेंसिव कर सकते हो, and all hypertension, stroke, hypertension controlled stroke, she has survived that and she is recovered, and ischemic heart disease under control, वगैरह वगैरह, they're all under control, etc. Good, shabash.
The treatment that was given to that patient was staging laparotomy due to right adnexal cyst, includes peritoneal washing, bilateral salpingo-oophorectomy, and mental biopsy. And the operative findings of that patient were right-sided simple adnexal cyst of 15 into 10 centimeter, a thin-walled right fallopian tube was atrophic, normal-looking, curled around right adnexal cyst. Right ovarian tissue was not identified separately. Few adhesions of small gut mesentery with bladder base. So the approach to the left adnexa was difficult. Left adnexa approach and the both left tube and left ovary were normal-looking.
और मेंटल बायोप्सी दी थी और उससे पहले हमने पेरिटोनियल वॉशिंग्स की.
Yes.
चलिए, अभी पेरिटोनियल वॉशिंग की रिपोर्ट तो आई थी.
जी सर, which
That's
includes
negative.
Negative. जी.
Now in this patient, the size is given here and it's quite obvious. Ultrasound में था उतना की size निकला है. So what kind of incision is required? अभी ना बताओ कि क्या हमने किया. What incision would you choose for this? ट्रांसवर्स कितने लोग चूज करेंगे? आप खड़ा करें ट्रांसवर्स वाले। ट्रांसवर्स इनमें हमने कौन सा इंसियन दिया था?
मिडलाइन,
लोअर मिडलाइन में
दे सकते हैं, क्या
नहीं।
दोगे? मैं तो वो
लोअर
पूछ रहा
मिडलाइन
हूँ।
कभी ताकि स्टेजिंग की प्रॉब्लम कर
हाँ?
लोअर मिडलाइन इंफ्रामलाइकन
सब मिलाकर मिड लाइन,
जी
वो क्यों?
सर अप्रोच में हमें लेवल को भी तो देखना होगा और अगर डायफ्राम एंड सरफेस सारा कुछ तो देखना है ना।
हाँ, उसमें because the suspicion of malignancy does remain there,
जी sir.
although there were no features on history, physical examination, or on ultrasound. And if later we didn't find, even at the time of surgery, there weren't any. But for such masses, it is important that the cyst has to be delivered as far as possible intact, so that the contents do not spill. If there is a rupture in the capsule of the tumor, that totally changes the state of the disease in the patient. And therefore, the incision should be such which would allow you safe removal of that. So therefore, we gave
Midline.
midline subumbilical incision in this patient and looked at that. And it is also recommended that you make a small incision initially and you go inside and look and see. Why small incision? Because sometimes the tumor may turn out to be inoperable. And if you make initially a large incision right from the sternum to pubic symphysis, that will be uh, not appropriate. So you make a small incision, you have reasonable enough for you to have a good look at the different structures.
Need be
And then you can extend it, of course, as much as you would need to for a safe intact removal of the tumor. So we in this patient gave a midline incision. Baki, from this look of it, it appears to be benign because it is thin walled, it has a smooth surface, it doesn't has large blood vessels over that. It did not have an apparent solid area along with that. There may be two locules of that, but not. But still, it is not possible to comment whether it is a serous cyst or it's a mucinous cyst. And if it is a mucinous cyst, then it's even more important to have brought it out intact.
Isn't the liver and diaphragm, the surface of diaphragm, that was all fine?
Huh?
Liver and under surface of
और
diaphragm. was all-
बाकी ठीक नहीं, बाकी चीजें जो थी, there were quite a few adherents or pelvic adherents थे, and as she mentioned that identifying and finding out that left ovary was not easy. We had to kind of struggle. Intestine was attached with the bladder also, और वहां से उसको किया, थोड़ा सा सेपरेट किया, और फिर हमने जो लेफ्ट pelvic area वहां पे we were lucky to find it out and removed it. That also looks normal. You can see a normal looking part of the ovary and also a small cyst which was reported on ultrasound. चलिए जी, अब इसको let's open it for discussion and comments. ये आजकल ऐसा किया करो, जब आप लिखते हो ना मैसेज तो जरूर उसको दोबारा से देख लिया करो, बिकॉज वो जो ऑटो करेक्शन है ना वो कुछ का कुछ कर देती है. Thin wall, B rule, M rules, thick wall, solid content for papillary, yes, multiloculated, bilateral, yes, bilateral or ascites. MRI is done for confirmation of cyst features. Ultrasound पे काफी ठीक निकल आते हैं, ठीक है. CT is for clinical staging. MRI done when ultrasound is inconclusive. Midline also. You give good exposure for inspection and palpation of other different structures for proper staging. Good. क्या ऊपर जरा चले, ऊपर भी और भी है या टोटली यही है? Mesenteric वो retroperitoneal mass, that's right, good. ये इनकी जो है डिफरेंशियल डायग्नोसिस में आती
फिक्स होगा ना वो एग्जामिनेशन.
हाँ, वो फिक्स होगा. वो तो उसमें तो पेल्विक किडनी भी आ जाता है, पेल्विक किडनी वो उस मैसेज में जो आ जाता है. सो यू विल मेक अ लिस्ट ऑफ दैट, सो यू शुड नो कि क्या क्या चीजें वहां पे हो सकती. एनी क्वेश्चंस?
जी सर, आई हैव अ क्वेश्चन। सर, ये ऐसा हुआ, शुरू में मैंने सुना शी वाज एक्सप्लेनिंग दैट द पेशेंट इज हैविंग नॉट सिम्टम्स, देन लेटर ऑन वी सॉ द रिपोर्ट्स दैट उनमें भी हमें कोई एम रूल के साइंस एंड सिम्टम्स नहीं मिल रहे थे, साइंस नहीं मिल रहे थे, तो एम रूल के हमें कुछ भी नहीं मिला है। और जी, तो आई एम थिंकिंग कि व्हाई वी वर नॉट टुवर्ड द कंजर्वेटिव मैनेजमेंट, हमने उसको थोड़ा टाइम क्यों नहीं दिया, हमने डायरेक्ट उसको सर्जरी क्यों कर दी?
नहीं, टाइम देने वाली बात नहीं है। सिस्ट विच इज 10 सेंटीमीटर्स और इस उम्र में 71 इयर्स की उम्र में हो, until and unless it is subjected to histopathology, you can't really say that it is that. Number one, that's important. So yeah, and this cyst is not likely to go away on its own. वो तो तब करते हो ना कि अगर वो हो इस तरह से, and I would not feel comfortable leaving an apparent ovarian cyst at an age of 71. Because if you आपका सवाल उस लिहाज से ठीक है कि जी 71 year a patient, high risk patient, anesthesia etc and all that, so pros and cons देखो, क्या ये है कि अब 71 की तो हो गए और कितना करना आगे, ये वाला एटीट्यूड वो जाहिर है वो नहीं लेंगे कि इतने साल के हो गए तो फिर आगे क्या करना है। सो देयरफॉर वो जो है उसके लिहाज से मैं आपका क्वेश्चन अपनी जगह, बट आई फील एब्सोल्युटली justified and I feel strongly that cyst should be, an ovarian cyst should be removed. मैंने जो अपने वो जो पुरानी किताब 1974 वाला एडिशन की मैं मिसाल की दफा दिया करता हूँ, आज भी सुबह मैं उस किताब में से कुछ चीज देख के आया हूँ, मैंने निकाली और उसमें से देख के आया हूँ, जेफर की प्रिंसिपल्स ऑफ गायनेकोलॉजी, बिकॉज आई स्टिल फील कि उसमें जो कुछ दिया हुआ है वो आज भी दैट मोस्ट ऑफ इट इज इट्स ट्रू. Now, he mentions a classical thing that when is the time to remove a cyst, and that particularly with the reference to if the cyst is identified concomitantly with the pregnancy. The pregnant woman और cyst है तो उसको कब remove करना चाहिए? तो वो उसके ऊपर रेफर ने लिखा हुआ था कि ideally the cyst should be removed now. Now means when the patient presents, तो उस वक्त है, except for those situations where you have to modify it. For example, if the cyst presents, an ovarian cyst presents at 8 weeks of pregnancy, you don't want to remove it at that time. You would remove it after 12 weeks or 14 weeks because of not depriving the patient of possible corpus luteum being on that side of that. Or if you find that there is a cyst at 32 weeks and it is not really causing problem and it is a chance finding, then you wait till she has delivered, and you can do either if you were doing a cesarean section at the time of that, or and you don't do cesarean section for removal of the cyst. So you, if the patient can have a vaginal delivery, then let her deliver. And in purpurium, we do that. Why in purpurium? That because at that time the abdominal wall is lax, and there is greater space, free space available, and the cyst would have a greater opportunity of getting twisted. So torsion of the cyst can take place. Therefore, it is generally so. The time to remove that a cyst should be removed, generally speaking, if the pathology is not known. Now, when we talk of, let's say, an endometriotic cyst, for that, in which an ultrasound and historical and ultrasound diagnosis of an endometriotic cyst has been made, in that case, I would hold my hands. I'll back off and I will not do cystectomy as early as possible. In that, there would be so many considerations. So, but in this case, in an elderly patient, yes, there is no question, at least not in my mind. अच्छा जी, वो एक सवाल है कि food exposure for ठीक हो गया. What is the difference between atrophic vagina and normal vagina? अब देखें ना, If I ask you, Dr. Sadaf Qazi, अगर मैं आपसे कहूँ कि please describe the appearance of a normal ovary, आप अपने पास पॉइंट्स लिख के रखना जरा, आप अपने तौर पे टेस्ट करो अपने आप को कि can you describe a normal ovary, the appearance of a normal ovary. And similarly, if I say atrophic vagina and normal vagina, अब मोटी मोटी सी चीजें ले लो, अब में से वो करेगा?
सर रुगाज होंगे,
रूगी, हाँ,
रुगी होंगे जो एट्रोफिक नहीं होगा।
नहीं, वो रूगी तो अगर if the patient is multiparous then the रूगी may not be there.
जी सर।
पहली बात ये है कि तो जब आप देखते हो तो what is the color of the vaginal skin, और vaginal mucosa, skin भी बोलते हैं उसको, mucosa भी बोलते हैं. So what is the color? Unhealthy, we are talking of normal vaginal wall. So उसका color क्या होगा? Color का difference होगा atrophic vagina में और उस, फिर उसकी laxity होगी. Vaginal जो atrophic vagina है वो उसकी elasticity नहीं होगी. It will be obviously, it will appear as if it's a thin walled structure. उसकी color जो होगा उसका rather palish होगा. It will not be that pink. And as a matter of fact, in atrophic vagina there would be areas which would be rather pale. वो उस तरह से होगी. And वो जिस तरह से मैंने बोला कि elasticity वाली बात नहीं होगी. हाँ, अलबत्ता जब आपने atrophic vagina और atrophic vaginitis की बात करनी है तो atrophic vaginitis में there may be purulent pussy discharge. वो जब वो होता है and you do not find कि वो or otherwise in your opinion it is not candidal or it is not trichomonal और थोड़ा सा purulent है, तो first diagnosis in a menopausal woman, post-menopausal woman would be atrophic vaginitis. If it is accompanied with that look of the pale pink look of the vaginal walls. Perimenopause age like 40 to 50 and simple cyst, तो क्या ये complex तो फिर management. पहली बात तो ये है कि perimenopause is spread over 5 to 10 years sometimes, at least 5 years around that, which may be 45 to 55 or sometimes like that. Now simple cyst, if it is there, depending upon what is the size of the cyst, what is the appearance on ultrasound, at that time you can wait, but if it's let's say a cyst is about 8 to 9 up to 8 9 centimeters, that still can be a follicular cyst. Occasionally, rarely, a follicular cyst can go up to that size, but then it obviously you will keep that kind of cyst under watch, and you will repeat ultrasound arbitrarily. I would advise that the ultrasound should be repeated for the cyst size every 2 months. And then also there is that thing that cyst can get, and if it is a persistent cyst, then it is better to be out. Now you also have to make a distinction whether it's a Farrukh cyst or it's an ovarian cyst. And a good ultrasonologist will tell you that there is this that the normal ovarian tissue or normal ovary is seen beside the cyst or slightly at a distance from the cyst. So you make a diagnosis like that, and if you find that it is ovarian cyst, then you can wait.
Sir, there are a few patients like they're so young at age of 35. They are they had a total abdominal hysterectomy. So in that case, if we see or diagnose an ovarian cyst, we follow which scoring system? I mean, we go for aorta group of classification or we do RMI scoring for that patient?
और देखो उसमें जो है ना जो क्लासिफिकेशन तो जो भी आप करोगे RMI कर लोगे या दूसरी कर लोगे वो, लेकिन the decision has to be made on individual basis. वो now we are talking, ये जरा मुश्किल से सवाल है कि 35 years और हिस्टेरेक्टमी हुई भी और इस तरह से, वो तो क्या हिस्टेरेक्टमी क्यों हुई, और ये कंपैरेटिवली अनकॉमन सा केस होगा ना जो इस तरह से होगा.
I think even the possibility iota is I think for premenopausal we use the iota classification or postmenopausal में RMI.
वो जैसा मुझे इस वक्त उनका याद नहीं है, लेकिन इंडिविजुअलाइज्ड उनकी वो असेसमेंट होगी और you go according to that कि आपने उसके मुताबिक उसको क्या करना है. लेकिन जिस तरह से मैंने कहा कि मैं तो उसके ये आप एग्जामिनेशन के लिए जरूर याद रखो, क्योंकि एग्जामिनर्स आपको पूछेंगे कि रिस्क मॉडिफिकेशन इंडेक्स एक्सेट्रा, या जो भी आप उसको करते हो तो वो आप उसके मुताबिक उसको देखोगे. बट आई स्टिल वुड से कि अपीयरेंस ऑफ द सिस्ट ऑन अल्ट्रासाउंड, वो वही चीजें आ जाती हैं उसमें भी, मल्टीलोकुलर है, थिक वॉल्ड है, उसमें कोई सॉलिड एलिमेंट नजर आ रहा है कि नहीं आ रहा, उसमें वास्कुलैरिटी कितनी है उसकी सिस्ट वॉल के अंदर, वो किस तरह से है. सो दोज थिंग्स. और देन if you want to keep it under watch and observation, then you will observe of some time कि उसका cyst के size में कितना कसर हुआ. Ovarian cyst with previous history of hysterectomy, patient was having multiple risks, known case of tuberculosis and type 2 diabetes. Same scenario. Now, with previous history of hysterectomy. अब cyst का size कितना क्या है ये नहीं मालूम. अगर cyst का size इतना क्या है तो I because after 40 the chances of the cyst or malignancy के chances बढ़ जाते हैं. But that is not to say that all ovarian cysts after 40 years would be malignant. Most of them still would be benign, but वो हो जाता है. So age का factor जो है वो तो वहां तक आ गया. Then other characteristics of the cyst, they will decide, and the features with which the patient has presented. Or if it is an incidental finding, let's say an incidental finding, a cyst of 12 centimeters or 14 centimeters, I would still be comfortable removing it. There is no point in leaving it behind. And if it is a comparatively smaller cyst, say 7, 8 centimeters, then I would keep it under watch, and I will observe.
सर
Patient
ये
has,
बिल्कुल इसी
जी,
एग्जाम में आया हुआ था हमारा जो अभी रिसेंटली हुआ, उसमें
हाँ
यही
जी,
इन्होंने बिल्कुल एज जो है 40 रखा था. तो
हाँ,
हम कंफ्यूज थे और पेशेंट जो है टीएच की हिस्ट्री दे रही थी और देयर वाज अ ह्यूज मास इन एब्डोमेन
ह्यूज,
दैट वाज.
ह्यूज था,
जी,
हाँ.
ह्यूज था जी
अगर नहीं
सर.
नहीं, मैंने तो अब जिस तरह से आपको कहा, मैंने तो 12-14 सेंटीमीटर की बात की है. 12-14 सेंटीमीटर इज जस्ट palpable above the pubic symphysis. अगर ह्यूज मैस है तो इट हैज टू बी आउट.
जी सर.
There is no discussion about it.
नो सर, दे वर ट्राइंग टू मेक अस कंफ्यूज्ड ऑन द सेम इशू कि आप इसमें कौन सी क्लासिफिकेशन करोगे.
That is actually unfair. That is
जी
absolutely unfair for the examiners to try to trap the candidates. You see,
जी सर.
that's not a good examination. You can ask appropriate questions, but
जी
you do not trap and you do not try to hoodwink
जी
the.
You can ask for
जी
justification. Not like,
नहीं, मतलब मैं तुम लोगों को बताऊं, जब मैंने SCPS का इम्तिहान दिया था बहुत साल पहले, तो one of my examiners was from Scotland.
हम्म.
I had a patient who was a young girl, 25, 26. She was very well educated. She had done masters. I remember her, and she had an ovarian cyst coming up to about 16 weeks size, 18 weeks size. So he just asked me one question. I said that she needs laparotomy. उस वक्त अल्ट्रासाउंड बस वहां पे नेशनल में किसी अल्ट्रासाउंड इतना ज्यादा नहीं था अवेलेबल, तो वो सिस्ट का डायग्नोसिस था. ही जस्ट आस्क्ड मी वन क्वेश्चन, व्हाट एनसीएन वुड यू गिव. मैंने कहा मिड लाइन सब मतलब उसने कहा शी इज एन अनमैरिड यंग गर्ल दैट अगली स्कार. आई सेड नथिंग डूइंग इट. आई डू नॉट नो द टाइप ऑफ सिस्ट दैट इट इज, एंड इट मे टर्न आउट टू बी दैट, एंड देयरफॉर ये 2-3 सवाल, ये टोटल मेरा वाइवा जो था उस एग्जामिनर के साथ, ही जस्ट वॉक्ड अवे.
किसी भी
दैट वाज इट. तो उसने, ये मैं आपको मिसाल इसलिए दी है कि बिकॉज जिस तरह से आप कह रहे हैं ना कि आपको वो फंसाने की कोशिश कर रहे हैं, दैट इज नॉट फेयर. दैट इज नॉट फेयर ऑन द पार्ट ऑफ द एग्जामिनर. वो अब ये है अनफॉर्चुनेटली इस तरह से कि जब व्हाटएवर, मतलब मैं इससे ज्यादा और क्या कमेंट करूं. अच्छा, अब ये देखो आप ना, you try to write whatever your question is in English, रोमन उर्दू में ना लिखो आप ठीक है ना. It was malignant ovarian tumor. Obviously, if it is a huge tumor, it's very unlikely that it will be simple, but it's more likely to be malignant. Few examiners rotate questions and try to. That's bad. That's wrong. 34 week size on examination. Inchy tape नहीं on measuring tape. ऐसे ना करो आप. 31, yes, that kind of cyst should be out. वो आ जानी चाहिए. Premenopause is.
इस तरह में आप कैसे स्टार्ट करेंगे
हैं?
इतने बड़े सिस्टम में आपकी इंसिजन हुई पहले लोअर मिडलाइन
नहीं ये बेटा ही ऊपर तक एक cyst होगी तो पूरा उसका तो देखा नहीं तुमने वो होता है वो पूरे इतना सारा cyst में कहा था. वो एक अलग बात है कि हमने 34 वीक्स की फाइब्रोइड यूट्रस का वो साइदा ने ट्रांसफर किया. चलें जी ठीक है. ये जरा अपनी लैंग्वेज पे भी जरा थोड़ा सा करो लड़कियों और अगर कोई लड़का भी है तो एनीवे ज्यादा लड़कियां हैं. चलो जी. If there are no more questions, thank you very much. अब जरा मैं तुम्हें तुम्हारी जो है ना